And we have a few minutes left for our panel. I'll have all the speakers join us down here. And if anyone has put a question, have you put questions on cards? We will collect those. And if you don't have questions on cards, we also have microphones so that we can have you speak. But if we'd like to start with the cards. Any? None yet? All right, no questions. Do we have the portable mics? Does anyone have a question in mind?
I have a question.
All right, good. Bruce.
So Lyndon, that was a fantastic presentation. You're a non-for-profit.
Yes, sir.
How do you support yourself? Where do the funds come to allow you to do what you do?
Well, right now, currently, we've been self-supported. I've been, been practically self-supported right now. And really just to get the word out there, and we're seeking funding. We do have nonprofit status. We have several, local contributors. But mostly I began this project, I really just self-supported, and we had a small grant was issued to us by Solution for Better Living. And so we constantly seeking funding because of the fact that just reaching out to so many different patients, it's overwhelming. Yeah. It's overwhelming.
Okay.
Mr. Carter?
Yes, sir.
Going through the experiences you had with dialysis, and there's so many clinicians here working in this.
Can everybody hear? Yeah, right. Okay. Is it on?
Okay. Well, there's clinicians here. What would you tell them? What would you share with them to let them know how they can better relate to the patient, treat the patient while they're going through dialysis?
I feel that one thing that that in my opinion, it's a lot of information out there, which is very good information. But until you deal with the patient from a holistic point of view, you will not get that patient engaged in what you're doing. Because if that patient is going through marital problems, which could possibly be, dealing with kidney disease, as well as financial problems because you have just lost the income, that patient is going to be unresponsive to what you have to say about phosphorus or potassium or anything of that nature, because that's not a primary focus, to be honest with you, and that's how I approached it. I mean, the moment I got my footing up under me through my personal life, I think that's when the change happened for me, because now if things are okay at home, now I can take better care of myself, or look for a future or see some positive things coming out of what I'm going through.
Okay, here's another question. Is the microphone working?
Careful, Susan.
We should have one station down.
Testing 1, 2. I'm the person that volunteers to work with Lyndon, and I met Lyndon. I just want to make a comment. I met him at St. Luke's Hospital in Houston, and he had a kidney transplant, and my husband here today had just had a kidney transplant. So I'm a caregiver. So the thing that, to add to what Lyndon was saying, I think, to your question, what would help the patients, I believe, would be some mental health as far as counseling and that type of thing. And what we've run into is, I found that we have to educate Medicare on the difference between Part A, Part B, and Part D. They don't know. So you spend a lot of time at the drugstore waiting for a prescription to get filled when they have no clue, and they're arguing with you all day long. The insurance company is saying this should be on the Part B, and then you fall into the donut hole, and then you go, whatever. So I think if the head ever realized what the tail was doing, then I think we could get further ahead.
Another question.
If I could follow up on that just for a second. I've been privileged for 30 years now to work in a VA system, and I take care of dialysis patients in the VA system, where patients are treated as people. We have wonderful social workers, and it really begins there. We have great interactions with those social workers and an entire team that's dedicated to those patients. And I personally, on my shift, look at them as virtually my friends. When I see them in the hall after dialysis or downstairs, I say hi to them. How are you doing? You know, you can make a tremendous difference in a person's life if you show that you care about the person rather than about the patient. And I think that's...
This is to Mr. Carter. I just want to say I was really impressed with your experience, and also the fact that I know it's hard going into the community to talk sometimes, because a lot of times people are not willing to listen or hear, and the information sometimes. But I live in New York area here, and I work along a lot of times with the National Kidney Foundation, and they give a lot of information. So when we go to the churches or just going out to any symposiums, we give out the information. And it's hard. I know it can be hard, but it's frustrating, but it's just worth the while. So I just want to tell you that.
Thank you.
This is really to the whole panel, and we heard all these great presentations on supply and demand issue and treating people as a whole and getting back into the workforce and treating people as people. I just wanted to know the comment on maybe if some of the nephrologists who are so busy practicing nephrology and maybe don't all seem to have the opportunity to say hello to the patients and didn't act as the primary care physician as much as they do, so that maybe another primary care physician could act as the primary care physician. Just wanted to know your experiences and your thoughts, because in my experience, it seems as if there's a very large percentage of the nephrologists who are sometimes by default acting as the primary care physician, but unfortunately due to time and money and all kinds of things, aren't necessarily doing the things that a primary care physician would do, even like saying hello and asking, how are you?
So it looks like I better start on this one. So nephrologists don't get paid if they don't say hello, how are you, do a physical exam, and write a note, okay? But your point is well taken, and many of us, for a number of years, have gone to working with nurse practitioners, and for over 10 years, all of the patients at Indiana University have a nurse practitioner, whether in the VA or whatever unit they're in, that sees the patient every time they come in, and we round once a week on our patients with that nurse practitioner who is really their primary care delivering person. And I think that we need to look forward in how to set up accreditation programs and teaching programs for nurse practitioners, or licensed, what are they called? Advanced practice nurses. So that they can specialize in an area, whether it's cardiology or whether it's nephrology or whatever, to be there on a much more regular basis to communicate with the physician, to deal with a lot of the issues, and allow the physician's time to be spent on more difficult or involved issues that involve integration of pathophysiology or medications or something like that. But you're right, there needs to be a primary caregiver. I think that's going to be a PA or a nurse practitioner in the future.
Emphasizing the importance of the nurse.
Oh, no question. When I trained, nurses acted like nurse practitioners. That nurse had a cadre of patients on each shift. She was their primary care deliverer. We went away from that in the 80s, and we're coming back to it now with nurse practitioners.
Dialysis units, and there are periods where you can do that. So he's very much concerned about the total well-being of the patients. Thank you for the question.
I want to comment on that as well. And one of the things that we've heard already is that if this is a person who is experiencing this situation for all of the reasons that led them there, having a top-down approach towards an individual is probably not the way to engage them, and that sometimes we need to start looking at what these teams actually look like, who's on them, and who leads them sometimes. There are experiments out there now in medical homes where it's not a physician or a primary care provider who leads the team, but a social worker who leads the team, or somebody who is a case management person, because the person is a whole person and has many issues. So if we approach it differently sometimes, and perhaps according to Mr. Carter identified that, there were so many other issues in his life that needed to be addressed beyond just the specific medical care or his compliance or lack of compliance, which is always the pejorative term towards patients, is their non-compliance. Rather than our own problems with communicating sometimes. But really looking at these teams as we move forward and trying to create a new model where perhaps it's not necessarily about the care that's necessary as it is about caring for the whole person who enters our system and in our environment. And that may not be the physician or even a nurse practitioner sometime. It could be somebody else who has responsibility for managing and making sure that all those things get done for that individual. And I think that's something that is moving in that way. We hopefully will get to the point where a medical home is really just a health home, and we have the capacity to provide all those services and support for that person who needs it.
One of the things that I think about when you ask that question, that providers are so busy, they're all very busy. When I look at the care team, everyone plays an very important role. And I look at it as a pit crew, for car racing, that when that car comes in, Mr. Carter's the driver, but we're all assigned to do something on that car, so he hits that road at the speed and win the race. And so we all play an important role, and I think one of the things I look at is the opportunities to improve our system by looking at what's coming through our day and being the bunny in the system. Oftentimes we think we know what the process is, but I would challenge you to follow the process, being the patient in the system, and sit there and track what that's like. Have the opportunity to have team huddles in the morning and see what does the appointment schedule look like, what's coming through my doors this day, and what are the roles that different people on my team can play to make that the most efficient visit as possible. The other thing I would like to say is last year my husband was very, very sick, and the family plays a crucial role. I'm sure Mrs. Carter played a very crucial role in your overall health. And oftentimes when the team of providers would come in and talk to my husband, who is a non-clinician, they would give him a blow-by-blow of what the day was, what medications were being provided to him. And I'd come in 15 minutes later and I would say, what did they say? He goes, I don't know. So, I would get really annoyed because I would say, over and over again, I would say, please don't come in and speak to him unless I'm there. He's not going to understand your jargon. And those are some of the simple things I think we could do if we consciously think about that and improve it. Basically, that doesn't take a long time to think about what's coming through our door, what are the team huddles, what are the roles that our team can play. And having that team huddle, with maybe the patient being part of that huddle. We're working currently across the state. It's been fun because my previous work has always taken me to work in federally qualified health centers. So it's the first time now that I'm really bridging out and working with the Hospital Association, American College of Physicians, American Family Physician, and engaging the membership organizations so that they can be the opinion leaders among their membership and helping to put diabetes on the front burners as a conscious thing to look at because of the rise of that condition, and also encouraging them to apply for the diabetes recognition because we're financially supporting that, but also the clinicians and helping to have more certified diabetes in New York State is another one that I'm really advocating for, to be bicultural and bilingual, because we have rural areas in the state, there is nothing. Primary care provider has to refer out. There is just nothing. They're out there in really rural areas in New York State. Believe it or not, I've driven across the state. There are signs that say, watch out for the moose and watch out for the cow. So it's like beyond the borders of New York. And engaging them in this helps them to kind of look at where they can make improvements. So I'm really working directly with the clinical partners across the state. And I'd like to expand that and include, we're not hitting our subspecialties as much. And I think that's a missed opportunity, and that's why I'm part of this, because I think it's crucial for me to partner with other specialists across the state that also bring this voice to type 2 diabetes and the roles that we all play in that.
One final question, I'll exercise the way. Judith, you raised, I think, an important point about the silos, about thinking, and I know, Bruce, you're thinking about this obviously at ASN, bringing nurses into, to change our culture and how we think about things. And how do you see that developing? Because clearly we need that, but there are plenty of obstacles. Wanda, you see it as well. Lyndon brought us practical examples of that, plus a best practice, I might say, in terms of something that could be done. So as we look around the country, whether it's a PIN program or ASNs, looking at what nephrologists and their teams are doing, how do we get beyond where we are in a constructive way and do that rapidly? I guess that would be my question for everybody, Bruce, Judith, Wanda, and Carter.
Well, I think that it's important to have some leadership in terms of what it is that you see for the future in terms of the patient population. If you're a nephrologist, you have your identified patients who are fairly advanced in the disease process, and that what we really need is nephrologists to be the ones to take some leadership in saying, nurses really do have a primary role in this, and and LPNs and dietary, and really say and make a statement about the importance of nursing being in, and others being in that care provider team, rather than being the sole voice and speaking from a medical treatment view, but really looking at it as a whole care team. I think the leadership piece is essential to be reaching forward, because I think there's some historical turf battles between physicians and nurses and other providers that unless somebody puts out the olive branch, they're not going to come. The nurses aren't going to approach the nephrologists. The nephrologists have to be the one to approach the nursing organizations and the education institutions to provide additional training and support as a way to really increase the access to care for their patients. And I always, earlier at the beginning, I wanted to make this comment. You said something about being at the table or being on the menu. And I always follow that up with, it's not about being at the table or being on the menu. It's about building the table and inviting others to come to your table and have dinner with you. Because if you're not in the leadership role of creating the table and voicing what the concerns are and the issues are, then you are left behind, because you have a duty and a responsibility to be the ones that build the table first and then have others come to it.
So I'll follow up on two issues. The ASN's council has been meeting with Anna every year at our national meeting. This past year we asked them to partner with us so that we could provide CME credits at our national meeting, initially for nurse practitioners, because they do very much the same thing we do. And many of them come, but they don't get CME. Many of them can't be reimbursed because they don't get CME. And we're still waiting for them to respond. We think we're building the table. The other big issue, I think, and I heard it broached this morning several times, is community awareness of kidney disease, the importance thereof, the necessity of the family involvement therein. I mean, look at the success, in cardiovascular disease. Look at the success in cancer. Look at the, diabetes is burgeoning on that success. They know what to do now. They just need to do it. We have to have community awareness of the disease and, importantly, what the patient family can do to help. And if we don't have a grassroots movement to get that word out, we are cooked.
So we need a grassroots movement as part of our professional associations, you're saying, really, in our...
There was a public relations person, Lynn Morrison, who in the 1980s, when I was very much involved with the American Federation of Clinical Research at that time, came to our national meeting and our local meetings, and she said, "You physicians are just crazy. You think you can run everything from the top down. You think you can say something and it'll happen. And until you get smart enough to have a grassroots movement that starts with a citizen-based population that then tells the government what needs to happen, you're not going to make any progress." Okay? And I think 20 years later we're starting to understand that. But the cardiologists and the oncologists beat us there.
I'm going to put, I'm sorry.
It's all been great to be here this morning. I think, as I've said a couple times, there's a tremendous opportunity. We need to come together. And I will say, Anna worked hard to get credits for our symposium this morning. The medical side, it was a little slower, but we're going to